Our next topic is respiratory distress syndrome. This often happens in premature babies. What is happening in the baby's body when respiratory distress syndrome happens? What is the physiology of this illness? Actually, there's a lack of surfactant in the lungs. Surfactant is a substance that lines the inside of the alveoli, or the small air sacs in the lungs. It helps to keep the alveoli open between breaths so that the increased work of breathing won't happen if the alveoli collapse between breaths. So without surfactant, the baby has to do a lot of work to take each breath. Each breath has to open the alveoli again from the beginning. Like you when you're blowing up a balloon, it's very difficult to get that first breath inside. So this causes a lot of respiratory distress for the baby. The oxygen exchange is also decreased if the baby is in respiratory distress syndrome. And other complications can also happen from this lack of surfactant. So what are the signs we'll see in the baby? What do we see when we do an exam? There will be severe respiratory distress, often with severe retractions or recessions in the chest. Also, grunting and flaring are common. The oxygen saturation will also fall, usually severely. So what are we going to do to manage these babies? How can we treat this? If it's very severe and the saturations are very low, even with oxygen, we need to refer this baby. He can be treated with artificial surfactant in a higher center. But if we are able to keep the pulse oximeter readings in a good range, then we can treat the baby at a smaller hospital. Mild cases can be treated with oxygen or even CPAP in the smaller hospitals. We want to see the range of saturations be between 85 or 88 to no higher than 95%. Higher levels of oxygen can damage the premature baby's lungs. Use the saturation as a guideline for how much oxygen to use. Don't worry about the liters per minute. We want to keep the saturation in a good range and not too high. You'll see some more hints as far as oxygen use in the general guidelines for oxygen. It's also important to give supportive care, good nutrition, warmth, and decreased stress for the baby. So how can we prevent this illness from happening? The best thing we can do is give steroids to the mother before the delivery of the baby. We should give steroids to the mother in premature labor when the baby is between 24 and 34 weeks of gestational age. However, it may also be helpful in late preterms if we know we have to deliver the baby by cesarean section. What dose of steroids will we use? Betamethasone can be given 12 milligrams every 24 hours for 2 doses. Or we can use dexamethasone. This will be 6 milligrams every 12 hours for a total of 4 doses. Even if you can't get all of the doses in, we should at least attempt to get some steroids into the mother before the premature birth. Steroid treatment can be very effective for the premature baby and also helps with other problems that premature babies can develop, such as intraventricular hemorrhage in the brain and other complications. The general guidelines for respiratory distress are to keep the saturation between 90 and 95 for term babies. They can be slightly below this in premature babies. We want to make sure that we wean the oxygen as soon as possible. Always give oxygen for cyanosis. As we mentioned, this means that the oximetry readings would be between 60 and 70%. This is very important. We want to give oxygen for grunting, always. This means that the baby is working very hard to keep enough oxygen in his lungs. Use a pulse oximeter anytime that you're giving oxygen to a newborn. We should also check the pulse oximeter anytime that the respiratory rate is over 60. And we should give oxygen only if the oxygen saturation is low or if there's grunting in the baby. The percent of oxygen can be increased by changing the delivery mode or even changing the baby to CPAP. Generally, if we use a nasal cannula for the baby, this will be the lowest delivery of oxygen. If we use a mask for the baby, then it will increase somewhat the amount of oxygen that the baby receives. An oxygen hood will give us the most amount of oxygen as long as it's on a high flow in liters per minute. We have to be very careful when using an oxygen hood. If by accident the oxygen becomes disconnected, the baby can suffocate. So we need to watch for this and connect things very firmly. CPAP is an excellent way to give oxygen to the baby, as it helps to keep the alveoli open between breaths. We will have another module on delivering CPAP for the baby. Some methods don't even require intubation. Apnea is actually not respiratory distress, but it is certainly a respiratory problem. There are several different kinds of apnea in the newborn. One is normal, actually. It is called periodic breathing. This is when the respiration stops for less than 20 seconds, there is no cyanosis, and there is no bradycardia from hypoxia. For periodic breathing, there is no need to give the baby oxygen, as this is totally normal. But dangerous apneas can also happen in the newborn. We can recognize them because they will be longer than 20 seconds, the saturations will fall, there may be cyanosis, and the heart rate also may fall. It is really important to monitor all babies that may be prone to apneas. Any infant that is born before 35 weeks, or any baby that is severely ill with sepsis, meningitis, or HIE. Their heart rate should be monitored and the pulse oximeter readings. Also, if you have an apnea monitor at your hospital, this can be used. So what will we do for management for these? Some mild apneas will resolve with stimulation, but if it's going on for any length of time, we need to then start the ambu bag and normal resuscitation for the baby. We can also treat the baby with medications such as aminophylline or caffeine citrate. You can see the section on prematurity for dosing of these medications. These stimulate the breathing center in the brain to help the baby to remember he needs to keep breathing. So what supportive care can we give to a newborn who is having respiratory distress from one of these diagnoses? First of all, we need to make sure that he is keeping hydrated and gets nutrition. If the respiratory distress is really severe, then we need to give him IV fluids until some of this has resolved. Once the baby has improved somewhat, we can start NG feeds. But if we put in an NG tube, we need to watch the saturations after this because we are blocking one of his nares and he is an obligate nose breather. In other words, breathes almost entirely through his nose. The saturations may fall when we do this. So we need to watch this. Once the baby is on tube feeds, then we can watch his progress and he may then quickly respond enough so that we can start breastfeeds. So in summary, if the respiratory distress is really severe, we have to hold feeding and just use IV fluids. Then we can gradually progress through NG feeds and gradually transition to breastfeeding, all the time gauging when we should advance by the saturations of the baby. Other guidelines for giving oxygen are keeping the head of the bed elevated We may need to slope the whole bed with the head up slightly. We never use pillows to do this. It is very important that the baby's head not be bent forward at the neck, which pillows can cause. Instead, we should position the head so that the mouth and the nose can be slightly extended so that the baby can breathe easily. We also want to make sure that he is in a neutral, warm environment and that the stress is decreased. Doing these things will help the baby to work less, to get oxygen into his body, and give him a greater chance for recovery. Thank you very much for watching this video today. I hope you've learned some new things about how to manage babies with respiratory problems, and that this will help you to save more babies in your everyday work. Now it's time to answer some questions about what we've just covered.